Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's July 2024 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is an Understanding Disease article that is entitled Oxalate Metabolism, From Kidney Stones to Cardiovascular Disease. It is authored by Dr. Galiniki Hawkins van der Singel and colleagues from Charité Universitats Medicine Berlin and UCL Department of Renal Medicine, University College London, London, United Kingdom. The prevalence of kidney stones continues to increase, with approximately 1 in 10 people experiencing a kidney stone during their lifetime. The most common kidney stone is calcium oxalate nephrolithiasis, the latter promoted by hyperoxaluria and the marked insolubility of calcium oxalate. In this masterful contribution to the Understanding Disease section, and beginning with the distinction between primary and secondary hyperoxalurias, Hawkins van der Singel et al. Outlined the far-ranging adverse effects of disorders of oxalate metabolism. Primary hyperoxalurias, of which there are 3 main types, are rare autosomal recessive disorders of glyoxylate metabolism, the treatment of which has been transformed by the introduction of small interfering RNAs that reduce hepatic production of oxalate. Prior to this major therapeutic advance, liver-kidney transplantation was the recommended therapy for primary hyperoxaluria type 1, the most severe of all the primary hyperoxalurias. Secondary hyperoxalurias arise either because of the following reasons. First, increased intake of oxalate or its precursors from dietary sources. Second, fat malabsorption with, accordingly, less calcium present in the gut to bind oxalate. Third, less oxalate catabolism in the gut and, consequently, more oxalate absorption from the gut. And finally, increased permeability of the colon to oxalate. The authors discuss new information regarding the roles of the gut microbiome, and Oxalobacter formigenes in oxalate metabolism and absorption. Secondary hyperoxalurias promote kidney stones and the development of oxalate nephropathy as calcium oxalate becomes inspissated in the renal tubulointerstitium. There is now substantial evidence that oxalate is pro-inflammatory as it activates the NLRP3 inflammasome, among other inflammatory pathways, with the attendant production of pro-inflammatory cytokines. Hawkins van der Singel et al. Review clinical and preclinical observations that link assorted cardiovascular diseases with increased serum levels of oxalate, and they discuss how such a linkage may be explained by the recognized pro-oxidant, pro-inflammatory, and pro-atherogenic effects of oxalate, as well as the adverse effects of oxalate on mitochondrial function. The vasculopathic effects of oxalate, the concentration of which is elevated in end-stage kidney disease, may contribute, as discussed by the authors, to the increased prevalence of cardiovascular diseases in end-stage kidney disease. Oxalate metabolism has also been linked to steatotic liver disease, and hyperoxaluria may contribute to the increased risk of kidney stones observed in obesity and the metabolic syndrome. The diverse adverse effects of increased plasma concentration of oxalate are perhaps best illustrated by the crippling multisystem disease, systemic oxalosis, that occurs in hyperoxaluric conditions when serum levels of oxalate become markedly elevated with the occurrence of kidney disease. This superb synthesis by Hawkins van der Singel et al. Expertly shows how perturbations in oxalate metabolism may contribute to its well-recognized complications. It summarizes new information regarding the pathobiologic effects of oxalate, and it outlines how oxalate may be involved in ways previously unrecognized in kidney, cardiovascular, and liver diseases. Our first highlight article this month is an original article entitled Social Induction via Social Behavioral Intervention on Changes in Metabolic Risk Factors, a randomized controlled trial in rural Appalachia, United States. It is authored by Dr. Eric Ding from the Harvard T.H. Chan School of Public Health, Boston, Massachusetts, and colleagues from institutes and universities in California and Ireland. The seminal social contagion theory of Christakis and Fowler proposed that social cues, ties, and networking promote the spread of certain non-communicable diseases, including obesity. Based on findings from their prior study, Ding et al. Questioned whether social behavioral interventions that promote salutary behavior may aid by reducing obesity and other metabolic risk factors. Social behavioral intervention may be applied at the macro level, for example, soda tax, food labeling, or at the micro level, for example, the influence of family and friends. Ding et al. Undertook a randomized controlled trial of the microclinic social network program on obesity and other metabolic risk factors in a rural Appalachian population where the prevalence of being overweight, 32%, or obese, 44%, exceeds the national average. Subjects formed small microclinic clusters consisting of 2 to 8 participants who were family members and or friends. Classes involved 2 or more microclinic groups and were exposed to a behavioral health education program that focused on nutrition, activity, and medications. Microclinic members were encouraged to promote healthy behaviors among themselves, their classes, and their communities. The trial was implemented from June 1, 2011 through December 31, 2014. And delivered weekly social health classes with the control group receiving standard care for 9 to 10 months. Analyses of outcomes were undertaken at the end of trial and again at 6 months post-intervention. Compared with the control group, the intervention was associated with a decreased body weight, waist circumference, hemoglobin A1C levels, and mean arterial pressure, and increased high-density lipoprotein cholesterol. Such improvements were generally sustained at 6 months post-intervention. Remarkably, statistical analyses demonstrated that these changes occurred for the most part independent of alterations in diet and activity, and that the social network effect was largely responsible for the improvement in weight and metabolic risk factors in the microclinic social network program group. Appalachian population where the prevalence of being overweight, 32%, or obese, 44%, exceeds the national average. Subjects formed small microclinic clusters consisting of 2 to 8 participants who were family members and or friends. Classes involved 2 or more microclinic groups and were exposed to a behavioral health education program that focused on nutrition, activity, and medications. Microclinic members were encouraged to promote healthy behaviors among themselves, their classes, and their communities. The trial was implemented from June 1, 2011 through December 31, 2014, and delivered weekly social health classes with the control group receiving standard care for 9 to 10 months. Analyses of outcomes were undertaken at the end of trial and again at 6 months post-intervention. Compared with the control group, the intervention was associated with a decreased body weight, waist circumference, hemoglobin A1C levels, and mean arterial pressure, and increased high-density lipoprotein cholesterol. Such improvements were generally sustained at 6 months post-intervention. Remarkably, statistical analyses demonstrated that these changes occurred for the most part independent of alterations in diet and activity, and that the social network effect was largely responsible for the improvement in weight and metabolic risk factors in the microclinic social network program group. Our milieu of family and friends provides for us connectedness and contentment within a cherished community. The remarkable findings of Ding et al. Now show that such a milieu and network may also benefit our health as they encourage us in the pursuit of healthy choices, behaviors, and lifestyle. Our second highlight article this month is an original article entitled Country Rurality and Incidence and Prevalence of Diagnosed Diabetes in the United States. It is authored by Dr. Sagar Dugani and colleagues from Mayo Clinic in Rochester, Minnesota, Wake Forest University in Winston-Salem, North Carolina, and the Centers for Disease Control and Prevention in Atlanta, Georgia. Certain diseases are more common in urban areas, such as, for example, infectious, cardiovascular, and allergic diseases. Rural areas, however, occupy the vast majority of land in the United States, and in such areas there is often suboptimal care of individuals with diabetes, a dominant national healthcare problem. Dugani et al. Questioned whether the occurrence of diabetes is altered in rural areas. These investigators utilized data from the U.S. Centers for Disease Control and Prevention Diabetes Surveillance System to determine the incidence and prevalence rates for diabetes in adults between 2004 and 2019. Such data were analyzed for the vast majority of counties in the United States, with counties stratified on 6 levels from the most urban to the most rural. The data demonstrate that the crude incidence rate of diabetes increased monotonically with increasing rurality, whereas the prevalence rate was also increased with rurality, but not monotonically and much less robustly. When adjusted for various socio-demographic factors, for example, food environment index, healthcare professionals, obesity, physical inactivity, no association was found for county rurality and incidence, while an inverse association between prevalence and rurality emerged. The authors suggest that these findings in the adjusted data may be explained in part by increased mortality of individuals with diabetes, such that with an unchanged incidence, the prevalence rate would decrease. More granular adjusted analysis revealed that an inverse association was also observed for rurality and incidence in rural counties in the Midwest and West. This study is important and timely, as it is the most comprehensive analysis of rurality-associated incidence and prevalence of diabetes, and it shows that both are influenced by potentially addressable conditions such as obesity and physical inactivity. You can access these highlights and editor's choice articles free of charge during the entire month of July. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you will find our online-only features and many news stories posted in News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well, and articles published online in press. You'll also find links to our social media by clicking the links at the bottom of the homepage to follow us on Facebook, X, formerly known as Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 Seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the homepage as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com/Mayo Proceedings, or journal updates on Facebook, www.facebook.com/Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, at www.twitter.com/Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.